G'day and welcome to a quick vodcast. This is something new that I'm trying out, and we're going to be looking at the SHED trial, which we talked about on the Broomdocs podcast in October edition. This is a bit of a deeper dive into the SHED trial, and I really wanted to have a look at this trial because it's an amazing trial, really well conducted, and gives us a really amazing batch of data which we can look at headache management in the emergency department. So just first, a quick shout out to the authors who were, surprisingly enough, all medical registrar trainees in the emergency system in the NHS over in the UK. And they did this trial pretty much through peak COVID. So the recruitment went from March 2020 through to February 2023. And there were 3,500 patients that were recruited and enrolled in this trial from 88 different emergency departments across the UK. Now that is a pretty amazing achievement. That sort of trial requires a lot of coordination and is a huge effort, and if nothing else, we should just take our hats off to the authors right now. So great work and well done. And I really love the way that they've presented the data here as well, because essentially this is a replication of the Canadian trials that were done, was it about 13, 14 years ago now, looking at the use of CT to diagnose subarachnoid hemorrhage in the emergency department. And so they basically tried to replicate the same set of circumstances and see if they could prove in the real world whether this rule actually worked. Don't worry too much about the rule, but this is a really good demonstration of how evidence works, and I think gives us some really good information about how we can manage our severe headache patients in the emergency department. So let's have a little bit of a look at the data. Just so that you know the sort of patients that we're talking about here, we're talking about patients with an acute onset headache. And if you look through the basic data that was used that's presented in the paper, you can see the patients here were pretty much 2/3 female, average age around mid-40s, and we always worry about the thunderclap headache, and about 2/3 of the patients in this cohort did have the classic thunderclap, i.e. instantaneous onset headache. And then there was a good trickling all the way through to 1 minute, 5 minutes, 10 minutes, all around that 10% mark, and right out to between 10 minutes and 30 minutes abrupt onset, that is to the peak of maximum intensity or severity of the headache, and right out to 1 hour, there was about 10% that got out to the 1 hour mark. So we're talking about mostly thunderclap headaches, but also anyone that had a peak intensity of the headache within the first hour. Interestingly enough, if you look at some of the other common things that they found, pain or neck stiffness was actually quite predictive of subarachnoid hemorrhage as a subjective symptom. So it's definitely worthwhile asking about. And they found that about 40% of patients had this symptom. And if you didn't have a subarachnoid, it was about 40% or just under. Or if you did, it went up to about 2/3. So that's quite a predictable thing, and definitely something you should be asking about. Most of the other factors that they were looking at were less predictive. Obviously, losing consciousness is a disturbing symptom, and those patients are all going to get a CT, hopefully. And then onset during straining was also roughly twice as likely to occur in the subarachnoid hemorrhage group as opposed to the people that did not have a subarachnoid hemorrhage. So that's also worth knowing. Vomiting was an interesting statistic as well. So about 1/3 of the patients in the whole cohort had vomiting associated with a headache, and it was about 1/4 of them in the non-subarach group, but it was over half in the subarachnoid hemorrhage group. So that was also a pretty discriminating symptom to ask about in the emergency department. Not much else really helped us too much. Obviously, the more severe headaches tend to present earlier, so they were more likely to come via ambulance, and the ones that are unconscious obviously were more likely to come via ambulance, so that was a bit predictable. But that's interesting data that's come out of this whole data set. Right, let's jump into some of the tabulated summaries, which I think are really worthwhile looking at just to get your teeth into what this data actually says. So the point of this study was to try and say, can we use a non-contrast CT early on in the investigation of a patient with a severe onset early headache in order to rule out subarachnoid hemorrhage? Now, the Canadian study that was done back in the day showed that this was probably something that we could do out to about the 6 hour mark with pretty good sensitivity. I think it was 99 point something % sensitive in the Canadian trials. However, if you look at the data as it's presented here, which is really nicely presented, you can actually see that the sensitivity starts out in that high mid-90s at the 0 to 6 hour mark, which is consistent with what we've seen before. And it stays pretty good up and around the 95% mark right up until about the 18 hour mark. And then the sensitivity drops off to about 75%. Now, most of us would look at that and go, 18 hours seems like sort of the sweet spot. After that, you may not want to use CT to reliably exclude subarachnoid hemorrhage. But if you look at the top line there, which is the pink stars, the negative predictive value, which is what that's representing, is actually consistently good way out until the 2-day mark. And the reason for that is that we know that sensitivity has to be interpreted in the context of prevalence. So the patients that turn up to the ED early and get their CAT scan early because they've got a severe headache are more likely to be the ones that have it, whereas the prevalence of the actual disease drops off quite markedly as you get further and further along in the timescale. So the people that are coming to the emergency department at the 2-day mark are much less likely to have a subarachnoid hemorrhage, and so therefore the prevalence is lower, and therefore a lesser sensitivity will keep a negative predictive value, which is in that happy range in the high 90s. So that's a really good EBM point there, is that when you're thinking about sensitivity, you have to know what the disease prevalence in the population that you're looking at is. And if you take all players, for sure, the sensitivity is not good enough if it's 75%. But if you look at the actual timestamps through the course of this patient's journeys, you can see that those that present early, that have the more severe headaches, the more worrying symptoms, are more likely to get picked up by the CAT scan. So I think that this data tells us that a non-contrast CT is pretty good, at least out into the 24-hour mark and possibly beyond. We'll look at some raw data in a minute, just so you can get a bit of a feel for what actually happened in this instance. So this is a very complicated table, and I apologize for that. I've tried to color code it to make it more simple to read. Basically, down the left here, we have the time window, so 0 to 6, 6 to 12, going right down to the past 1 week stage. And then we have the trickle down of when these subarachnoid hemorrhage diagnoses were made and the mechanism by which we were made. So the blue column here is the patients that got a non-contrast CT that were ruled in, and then obviously some were still not ruled in after a non-contrast CT, so they went on to have a CT angiogram or an MR angiogram, which is the red column. And then the yellow boxes here are all the patients that were picked up on the LP, essentially. So they either had blood on the third tube or decreasing blood as it went on, or increasing blood, as it went on through the different tubes on the LP, or they had blood and then it was confirmed on MRI later. And then the last column, the mauve purplish column there, are the ones that were missed essentially and were found at follow-up to have had a subarachnoid hemorrhage, which was not picked. And as you can see, there was only one patient which was not picked. So that's quite reassuring that we weren't missing too many if we used our standard sieve. But let's dive into this a bit deeper. They've also broken the data down here by aneurysmal subarachnoid hemorrhage, which is the one that we all worry about. These are the patients that have a aneurysm which is likely to rebleed and could potentially kill them. And these are the ones we have a therapeutic intervention for. So these are the ones that go off to see our interventional neuroradiologists and have a coil put in, or sometimes go off to theatre and have an operation on their brain to clip their coils, clip their aneurysms. And so this is the group that we really care about, because these are the ones that time does matter and we need to make that diagnosis early and we have a good treatment for them. The non-subarachnoid, the non-aneurysmal subarachs, they're also a severe headache, but these patients are universally treated conservatively. It's unusual that these patients get an operation, and they usually have conservative management. Now, they still need to be watched closely, but it's not such an issue if they don't get picked up straight away. So we're really most interested in the aneurysmal subarachnoid hemorrhages, although as you can see, they are much more common than the non-aneurysmal ones, and the miss rate for the non-aneurysmal ones was appreciably higher in the early phases. So if you look in this first box here, we can see in the aneurysmal subarachnoid hemorrhage group in that first 6 hours, CT scan picked up 66, and it picked up pretty much all of them. There was only one that was missed by CT scan in that early group. and that was picked up on xanthochromia in the LP. The non-aneurysmal ones, obviously there were 2 missed, so it was nearly 10% were missed, and they were picked up on the LP as well. So it's interesting data, and if you go all the way through the different timestamps, you see that the misses get rarer and rarer and rarer, and once we get down, we see pretty much no misses in the aneurysmal subarachnoid hemorrhage group, way down to, it's really just one patient that was missed at the 1 week to 30 days mark, and that is pretty rare. So out of the many patients who were actually diagnosed, the vast majority, so I think it was 267 subarachnoid hemorrhages in total, 208 were picked up immediately on the non-con CT, doesn't matter when you had it, and then there was a trickle of other patients that were picked up later. Only 4 of those were picked up on CT angiography or MR angiography, and that's a pretty small number when you think about the number of those that you'd have to order if you're going to use that as your second line investigation, whereas the LP picked up additional information in about 24 cases. So about 10% the LP was actually useful, though the vast majority of those were in the later presenting headaches, which is interesting in and of itself. And that's one of the things we've been teaching for a while, is that the CT is good early and LPs maybe better in that sort of middle group, the ones that are presenting in that sort of 12 to 24 hour window, and that the data certainly shows up in this here to support that. So interesting stats, have a look through them, take a bit of time to get your mind around them, because it is quite useful to know what all this means. So this is a table that I've generated by looking through this data. Now, if you look at all the bad things that could have happened, so we're looking on the left-hand side here. If you look at this trial, there were 234 subarachnoid hemorrhages. There were 56 other bad stroke-like events or bleeds within the brain. There were 63 patients in this cohort that had a brain infection. There are a few that had space-occupying lesions, so a tumor or metastatic disease. There are also a good number that had benign intracranial hypertension, and central venous sinus thrombosis was represented in this group as well. But then if you take out all the patients that would have been picked up on a normal non-contrast CT and see, of all these bad things, what's left over, this is what we get on the right-hand side. So we're taking out pretty much all of the subarachnoid hemorrhages, because we know that we're 95% sensitive, so there's only a few that are getting through to the keeper on that one. And also with other bleeds and strokes, there's not many of those that we're missing on that initial non-contrast CT. So those are represented by the small yellow and red lines at the top. Obviously, CT is not great for ruling out infections, so the vast majority of infections are still going to be there, and that's the big worrying group. We're not going to miss too many space-occupying lesions, I hope, on a non-contrast CT. We may miss 1 or 2, so I've left a little bar of purple in there. And obviously benign intracranial hypertension and CVST are much harder to pick. So I think that's an interesting way to look at this data. So if you take all patients to the ED that have a severe maximal severity headache within the first hour of their symptomatology, they've come to the ED. Those that have gotten a CT, which is the vast majority in my practice anyway, the ones that you're worried about a subarach, and you've got a negative CT, so you don't think they have a subarach based on the CT, there's a small chance that you're missing one, but what you're left with is these things which LP is really good for diagnosing. So LP is really good for diagnosing infection, and it's also the way that we diagnose benign intracranial hypertension. Central venous sinus thrombosis remains a tricky and enigmatic thing to diagnose, and so I think you just need to keep that one in the back of your mind. And obviously there's a particular cohort with risk factors that you need to think about as well. Now, does that mean we need to do a lumbar puncture on everyone that's had a negative CT? I don't think it does. I think that we can use our clinical judgment here. So what we're really looking for people that fit the mold of benign intracranial hypertension, so they may be women who are maybe overweight or taking oral contraceptive pill or have that previous diagnosis. That's certainly useful to know. And we can look at people that might be prone to having central venous sinus thrombosis, so whether they've got thrombophilia or they've got another infection inside their head which may have triggered this. These are things that we can think about as clinicians. And that leaves us with infection. And generally we're pretty good at picking infections, so patients that obviously have fevers or other risk factors that may be immunosuppressed, or patients that have had recent surgery, for example, or obviously the ones that look febrile, look encephalopathic. This is the group of patients who you may then go on to do an LP, not so much to rule out subarachnoid hemorrhage, but to rule in whatever infection it is and find the right bug so you know what you're treating. So I think we still do need to do LPs, but we need to think about it after we pause and have seen a normal non-contrast CT of the head. So really useful data, and this is certainly going to guide my practice into the future. I think patients with severe headaches can have a CT with no contrast. We can then pause, look at the CT, and if the CT is completely normal, this is what we're left with. And then we need to make a decision. Does it make rational sense to go on and do an LP on all of these people? And I think those with risk factors for the above, it certainly does. We can look at the blood tests. We can look at other things in the history at that point and decide whether we think this is worth pursuing. And obviously we can talk to the patients at this point as well. So if they're otherwise well and we don't think they have an infection and they don't have any specific risk factors for any of those other diseases, then this is the group that we're going to enter into a shared decision-making discussion with. And if they want to have an LP, that's by all means not an unreasonable and very safe thing to do, but we can also avoid a lot of wasted time in the emergency department by not doing an investigation, which may not give us really much in terms of patient benefit as well. So those are my thoughts on the SHED trial. Leave some comments below. Let me know what you think. But I think this is a really useful data set for us into the future.